Anybody is here and they can share it on the Area Circle Professionals page. I forgot I did not do that. And then tag everyone. If any Area Circle girls are here, please help me out. Alrighty, everybody. Welcome, welcome. It is Friday night instead. Is it Friday?
It's
Friday. Sorry, everyone. It's Friday. Everyone should be at happy hour. Sorry.
We're going live 5 times this week. It is so busy over here. Wow. So we're going to start our podcast recording tonight. Of course, you guys all know Nicole is our wonderful host. And we have these 2 guys down here that you guys might not have met before. One of them is Dr. Kevin Coppelson. And then we have Dr. Zaghi. We're going to be talking about some awesome stuff. But right before we start, we're going to play a game. It is called
Guess the Gap.
So let's guess. Yeah, so I'm going to share my screen and you guys got to type. Area Circle girls, if you guys can keep up with whoever is typing, the first person that guesses will get a prize. Is everybody ready? Do you know
whose gap this is, right? Not the size of the diastema, but who it belongs to, right?
Yes.
Okay.
Anybody? Can you guys see the photo? No. Anybody? Okay, let me share.
Someone put Renata.
No.
Madonna.
No. Plus, where's my downloads?
We got Mick Jagger's daughter.
Yes, who got that?
Oh my gosh, someone just posted. Someone put that.
How did you get that?
Wow.
How did you get that right? That was so
Davis
good.
said she is a model.
Mm-hmm.
Okay.
Why is this not showing? Hold on. Let me.
Yeah, that's pretty impressive.
That was very impressive. Good job. There she is.
Oh, yeah. I see the short upper lip. I won't start doing it.
I know, right? All right. Next one. Everybody ready?
Another good one.
Yeah, that was my guess as well.
You got that one.
I see a little bruxism there too, right?
Yes, I did not have the main photo, but this one is Madonna. Ashley got it. Very good. Next one. This is a tough one.
It's fun. I don't know who that is.
He was younger in this photo. He was younger, but he's so handsome now. Does not look like he had a deal.
David Letterman.
No. Anybody? Ta-da!
Oh,
Isn't that crazy? Zac Efron. Okay. All right, just a couple more. Can you guys see it? Anybody?
I think I know that one. I think I know that handsome man.
Actually. You got
That's a good one.
All right. Who do we have? This one. Does anybody know who this one is?
That's a bad one. That person needs a tooth cleaning.
That was Nicole. I
can only say that because that's me. Or it was me. Who's that?
That is me. And last one. Everybody needs to know this one.
Yeah.
Who's going to answer? All righty. Terry Patrick got it. Thank you guys for playing Guess the Gap. I had a few more, but I don't even know who half of these people are. And I really think that our diastemas look so much better than their natural diastemas. I have to agree, Dr. Zaghi and Nicole.
And I have to show you guys one funny thing. If I hide my photo, or my video, see that picture of me. So that's my work video, right? I can't really, or my work photo. I can't zoom in, but they happen to be taking office photos when I had a huge diastema. I mean, maybe up to millimeter. It was so big. And I'm like, oh my gosh, you have to plan it this day. So I asked the photographer, could you actually fill it in with Photoshop? So that's actually a fake photo. I had a huge gap and you put white in the photo to fill it in. So y'all know my secret. But the funny thing was the photographer had a huge diastema just naturally. And when I asked him, could you fill mine in for the photo? He's like, well, why would you want to do that? And I'm like, well, yours is natural, mine isn't. It's a really long story. Like only us Airway people would get that, but it was really funny. So that work photo of me is actually fake white in between my two front teeth, photoshopped.
Guys, please keep all your videos and microphones off while we're live because we're recording. Nicole, go ahead and you're welcome to start your podcast.
We have two amazing guests, and I'm not going to do bios because everybody should know Dr. Zaghi and Dr. Coppelson. So hopefully you all know them. Dr. Coppelson is Dr. Zaghi's oral maxillofacial surgeon who did the procedure for Dr. Zaghi. So we just want to hear all about your status and updates, Dr. Zaghi, on what procedure you had and how you're doing. So maybe we can start by Dr. Coppelson explaining the name of the procedure and what it was, and then we'll ask Zaghi some questions.
Yeah. So the procedure we did on Dr. Zaghi is called MIND. It stands for minimally invasive nasal maxillary distraction. Basically, it's a way to get adults to split in a very airway a positive way. So if you guys want, I can show you kind of like the traditional ways that we used to perform maxillary expansion on adults. But basically, the old way is very a low level of expansion. It's what we call Lefort 1 level expansion. So you got very minimal improvements to nasal breathing. It's also a very invasive operation. A huge incision, big dissection, and subsequently lots of pain and swelling and bleeding and things like that. So the MIND technique basically is a minimally invasive operation. It's all done through 3 little ports in the mouth. Patients have, very little to no pain afterwards in general, and very little to no swelling, just a little bit of upper lip swelling. And you get a very favorable expansion for nasal breathing, for your palate, so that affects your tongue space. So I like to say it's the best of both worlds. It's minimally invasive and maximally effective. Yeah, so Dr. Zaghi is, I think, about 1 month done from after he stopped turning. He got about 7 millimeters of expansion. And I'd love for him to explain, I guess, from his end as a patient, how it's gone and what it was like.
Yes, can I ask one quick question, just so I understand? So you go in the mouth and you do 3 ports, you said?
Yeah. So there's 3 like 1/2-inch incisions in the mouth.
Okay.
Like this big. Yeah. Like couple sutures to close each one, like very, very small incisions. And I operate through the ports. I free up the sutures in specific places. I free up the septum of the nose so that you don't get a deviated septum by accident during the expansion phase. It just helps things expand, more symmetrically, as symmetrical as possible. Get as much anterior posterior expansion as possible. And it's all done through 3 ports versus like a Lefort incision is first molar to first molar, huge dissection up to the infraorbital nerves. It's like totally different operation.
And the location of these incisions are where?
1 anterior in the upper lip and then 2 posterior behind the molars. Yeah.
Great. Okay, Dr. Zaghi, let's hear how you're doing.
All right. So I'll just give you a little bit of a background on my history altogether. As you guys know, I went to Harvard Medical School, UCLA ENT residency, and it wasn't until I got into fellowship that I realized I was a mouth breather. I go back and look at some of my, early videos, and my mouth is always wide open. And as I got more into it, imagine I went to ENT school and I graduated. I didn't know I was a mouth breather. It wasn't until I got into fellowship that I even knew that I had this anterior open bite. So let me just show you this picture, this amazing presentation that Dr. Coppelson prepared. So I had this open bite. And so, me in the tongue tie field, everyone's coming up to me. Do you have a tongue tie? Let me release your tongue tie. I have no tongue tie. I would study the grading of tongue tie to see maybe I have a tongue tie. I tried my functional therapy. That wasn't it for me. Okay. I had a tongue thrust, yes. but because I wasn't breathing through my nose, and I had a very, very, very narrow palate. And so while I was in fellowship, I was thinking, what should I do? Should I do my nose? Should I do dome? And it was just early on. This is 7, 8 years ago. It was big, big incisions, big cuts. And I was like, I know I need that, but I don't know. So I put it off a little bit. And then I explored a TAD-based expander. Didn't really work for me. I tried Prozac, which did help with my palate expansion. Dr. Coppelson will show you guys. I did Invisalign. And then once I was all said and done with my Invisalign, I thought I was so proud of myself. I closed my bite. It was Mariana Evans at, I think it was like Dawson Academy meeting or Spear Summit meeting. That's what it was. And she looked at me and she said, "That's not stable. Like, why didn't you just do Marpy? Like, what do you like you have so much recession, like your teeth are totally tipped. Like, what are you joking yourself?" He's like, you have a narrow palate. Like, you got to get on board with this. And then I asked Rebecca Baca, what do you think? And then I asked Audrey, and he's like, Audrey's been like, I've been asking you for years to do this. Come on, like finally. And meanwhile, I'm seeing Dr. Coppelson operating sometimes just in his clinic, just in like the room next there. He's sitting there doing these procedures, and patients come in and out. And this is the guy who convinced me to do it. Okay,
Beautiful.
Sure, nasal breathing. Sure, bigger palate. But the selling point is, man, look at those cheekbones. Wow. This is like an airway procedure, but I mean, wow. This person looks like an athlete. He looks good. He looks healthy. And, part of it was for, cosmetic reasons and for, just to look cool. Let me share this with you guys. Oh yeah. Good stuff, man. Right? Nothing like a diastema, nothing like these cheekbones. I feel like I have much more symmetry in my face, but that's not why I did it. Ultimately, why I did it was that I had tongue thrust, gagging, getting lower back pain. When I closed my open bite, it actually trapped me, and I started getting really bad lower back pain. If anyone's seen me lecture for too long, it was like hard for me. So having the open bite actually was like adaptive for me. And when I closed my bite, I tightened up. So I went for the mind procedure. I did the split. I felt so loose. I stopped getting lower back pain. I went really slow with my progress. I wanted a symmetric result, so I did a ton of body work. I mean, like 3 times a week I would do body work. Okay,
Wow.
I had a chiropractor. I did like oralays, biolays. I did like 800 nanometer wavelength, 1064 nanometer wavelength, shockwave. I did all the lasers. I did chiropractic. I did CST. I did Chinese medicine. I did like everything for my posture. I did Pilates and just to get it right. And I'm so glad that I did that. And it gave me a lot of insight, because the biggest risk with doing these procedures is asymmetry. So if you're sleeping on your face, if you're tongue thrusting, it doesn't split. It can be a little bit asymmetric. But mine, I feel like, was very symmetric. I'm breathing a lot better. My posture is better. I don't have the gagging. I don't have the tongue thrust. The open bite tendency is already closing on its own. And it's been a terrific experience, really smooth. And I'm so happy to have had Dr. Coppelson do this procedure for me. So why don't you share with them my case, my CT scans, and share with them my journey. Can you do that for us, Kevin?
Absolutely. Thank you for letting me cut you open, Dr. Zaghi. It was an honor of my career. So let me pull up your slides 1 second. So
That is amazing. How exciting.
So I'm
It's
gonna
cool. It's you know, and I published some one of the initial papers on this, but it took me a while to warm up to it. But I feel like really we're there as a field now, especially with the custom MARPI that's possible. Yeah, so go ahead and share the case, Kevin.
And
Yeah.
where, Dr. Coppelson, did you develop the mind technique, or is that
Yeah,
developed?
like I did. It was through a little bit of trial and error, to be honest, in the beginning. So I when I came out, I was doing a lot of domes, which is, you know, basically a traditional surgery. And then I started doing the ease procedure, which is a great procedure. But some of the cuts, you know, the approaches and actually like the method in which you do the cut, where you do the cuts, I felt like I could be more effective through a different approach. I still wanted to get the same type of expansion that you do get with the ease procedure, which I think is very, like I said, airway favorable. But you know, I felt like I could do it a lot more predictably, get faster expansion, doing it a different way. So, yeah. So
Yeah, and I'll just kind of summarize as well that you know, traditionally you have the MARPI, no surgery, but the suture is super fused. And in my case, Dr. Copeland said it was like extra fused. All right,
mhm,
and he
yeah,
had to
strong
like
bone.
really
Yeah.
like work hard to split it. And when you want to split it, you can do different things. You can deglove here and cut all the way and go all the way back. It's like a big operation. You can go inside, like how to do with corticopuncture, but then you risk like nasal palatal fistulas and the intraoral wound. And a lot of people do it that way, and that's fine. But the way Dr. Coppelson, I've seen him do it, makes a super small. I'm like, that's it, like a super small like lip tie incision, and then he gets it like really nice and steady, and is able to get like a perfect split. Because my biggest worry was asymmetric split, right? When if you're just kind of guessing, you know, puncturing it, it's like tearing a piece of paper, and you know, sometimes the piece of paper will come out straight, and sometimes it'll go off to the side.
Mm-hmm.
And so I was like really worried about like an asymmetric split. And so, you know, go ahead and show them how like perfectly in the middle you got everything.
Yeah. Yeah. So I mean, that's a great point, right? So, you know, there's all kinds of different techniques out there, right? There's people that do some version of a piezo surgery through the palate. Obviously, I don't do it that way. I think it can be traumatic, and there are some potential complications that can come from perforating the palatal mucosa. So I take care to not violate the palatal mucosa when I'm doing this procedure. Also, like
Yeah.
one of the other benefits of mind is that the expansion is started basically right away. Like in the operating room, I know that person has a beautiful split. They're expanded up to, you know, I don't know, whatever I feel like. I want to make sure everything's nice and loosey goosey. I get them open and then I close them back up at the end of the procedure. So we know there's not going to be a lot of hiccups in the in the expansion phase. Like everything's loose, everything's mobile. Go ahead.
Yeah, and then one other thing that's important to me, I had prior septoplasty, okay? And it was really important for me for my septum not to shift. If you get an asymmetric split, then it's possible that your septum can shift off to the side. When he does it from this perspective, he's controlling the septal split so that it's super controlled and separated, so that when you separate the maxilla, the septum stays straight, and it's not going to carry one side or the other, and it won't affect people who've had prior nasal surgery.
I have a question, Dr. Zaghi. Is this you?
This is me. So this is me before my Crozat. All right, this is me at baseline. Look at the
Dr. Zaghi, your tongue is low.
Low tongue posture, low tongue posture, weak low tone. Hit me with it. Tell me.
But you've had the MARPI, right?
Tell me I need a frenuloplasty. Yes, I have a tongue tie.
Wait, I do have a question about a septoplasty. I think I remember learning in dome, you might want to do a septoplasty after the dome because the bone is so hard that it's harder to do the dome procedure. I don't know if that's correct.
That won't apply to. So it won't apply to mind. Okay, so when you go do dome, you're stripping the nasal floor. Okay, so if you've had a prior nasal surgery and they're trying to lift the nasal floor and lift the nasal septum, you can get a septal perf. It makes it a lot harder for them. So they prefer native mucosa, so they don't have to do that because it's a big dissection that they're doing. This procedure, you're going low, and you're unlikely to hit the scar tissue from the prior septal surgery, and not going to cause problems with septal perforation because I don't have cartilage all the way through. They took out some of my cartilage. So if you're not careful, you can tear the mucosa and cause septal perforations or deviate the septum, especially after prior septal surgery.
Okay.
Yeah. And that's another great point is on the timing, besides what Dr. Zaghi said, which is absolutely correct. And that's a complication you don't want to have. What I also tell my patients is you may not even want or need a septoplasty once we're done expanding you, right? Your nasal breathing may improve so much. I've seen septums that were deviated by the time you broaden that high arch palate, drop that floor down, widen it, the septum kind of unbuckles a little bit. And so I'm like, maybe you won't even need it. Why don't we just wait? Right. And so that's the other thing. But, unfortunately, I have seen a few patients walk through my door that did have non-surgical expansion somewhere else. And one of the bad complications that can happen is that your septum can attach to one side of the maxilla. As you expand, it'll just pull it off and create a really nasty deviation that can cause a bad external deformity. So I don't think it happens a lot, but I've definitely had a few of those people walk through my door. So I do take time to free up the septum so that doesn't happen. So this is Dr. Zaghi, 2019, pre-Crozat, anterior open bite, intermolar width of 34 millimeters, maxillary skeletal width, so this is measuring the bone width, 62.5 millimeters. This is, the basal width of the bone at the area of the first molars. Here's his nasal aperture, 23.3 millimeters. Okay, this is how wide that nasal cavity is. This is Dr. Zaghi.
Turbinates, right? Are the turbinates really enlarged?
I did have a problem with turbinates, and I had it reduced once, and then I had a septoplasty turbination after this.
Okay.
Tongue's better.
So this is post Crozat. Okay. Intermolar improved to 37 millimeters about. Nasal aperture is the same. Maxillary skeletal width is the same, right? So what you're seeing here is an increase in intermolar width, but no real changes to the skeleton, right?
And then notice another thing, that my tooth here on the second page, they're really being pulled toward the buccal mucosa. It's almost coming out of the bone. So
this is what we call dental alveolar expansion, right? So it may allow you to have more tongue space, but
which it did.
And your tongue is up. Did you have myofunctional therapy after the 2019?
All throughout. I mean, I'm lecturing on it. I'm learning. I'm trying different things all throughout.
Okay. Because now your tongue is up in this photo, so there was more space for the tongue, but your nasal breathing and your nasal airway didn't improve. This is really good to see. It's
a great example that the first case is not a myofunctional therapy case. Orthodontists out there are going to send those patients with an open bite, trying to get us to fix it, but it's a structural issue. You have to fix
it. Meanwhile, if you don't know that you're so what we talk about is phasing it out. So the first phase of myofunctional therapy is, hey, tongue is supposed to be up, chew on both sides, try to swallow, don't do all these habits, right? And if patients don't know that, if they're have a habit of biting on their pen and then they go do orthodontic, they're gonna get messed up. So we always say in our institute, start with therapy just for a little bit. Just get your feet warm. Understand the principles. That's phase one. Address the root cause. What's the root cause? Is it tonsil? Is it nasal? Is it ortho? Get the root cause. Then come back to really hit the myo, and then do tongue tie if necessary. But I just want to give credit to that if you don't know about these myofunctional habits, that you're supposed to keep your tongue up, the expansion won't work, and it'll be asymmetric, and you'll have problems. So I would say some more collaboration.
Work together.
Closed open bite with myo alone, obviously, right?
Exactly.
Go ahead. Yeah.
Right. So 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 there's a scan missing, which is like his pre-mind scan, and basically where he was at, the teeth had basically relapsed. So his intramolar width back down to 34.
Wow.
And then obviously everything else was the same, right? But I think his anterior open bite was closed orthodontically. And they also undid some of that tipping that he had. And then this was him after mine. So this is in July 2022. So this is about a month ago. All right. 42 turns in. He has
Wow.
beautiful expansion. Intramolar width up 7 millimeters. Nasal aperture up 3 millimeters. All right. So now air can pass easier through the nose. Nasal obstructions down. Airway resistance is down. So people don't have as much obstructions and arousals in their sleep. Dr. Zaghi is not the most extreme I've seen in improvement in his airway. I have actually another one I want to add to a talk, but everyone gets a little bit of a bump in their minimum cross-sectional area when you look at a 3D rendering of their airway. It's pretty amazing. You widen the palate, more space for the tongue, the posterior airway space opens up. And then you get a second bump. I always tell patients, once we get the appliance out, and now you have another bump in tongue space, patients always report a second little improvement in their breathing and their sleeping. And then Dr. Zaghi got another scan today, and you can see
That's
in
for our
1 month.
show. Thank you.
And I guess another thing I want to point out is, look, he had almost no tipping of his teeth, right? So when you have a surgical release, you're really just getting skeletal expansion. You're not getting like that dental tipping with the teeth flaring out. You know, I would say the angulation of his molars is the same throughout. He didn't really get tipping during any of that expansion phase, which I think is very favorable. And Dr. Zaghi was a little high risk because he's been through Crozat, so many rounds of ortho. He has some recession, so we really wanted to make sure that we didn't worsen his recession, push the roots out.
Is that before my Crozat, or what's the pre-op? Is after the
I
Crozat,
think
or
this is before anything. Yeah, I think
before
this is
anything?
original scan. And so you can see the nasal aperture widened, and now I asked him today, I was like, what are you eating, Dr. Zaghi? Because in 1 month, that bone is like filling in like crazy. So he's eating well, he has good nutrition, and you know, he's definitely ahead of the curve with the bone filling. And this is the kind of simulation of what's going to happen afterwards, right? So this is the orthodontic phase that he's doing now. We're going to close that diastema and sink in that bite. And, you know, people that have anterior open bites at baseline, you know, they go to an orthodontist closes it, patient leaves happy, few years later, it relapses, right? Because they're not treating the root cause, which is insufficient tongue space, right? So this is like a more permanent solution, right? You address the tongue space, then when you orthodontically close it, do some myofunctional therapy, and the patient doesn't have a relapse. They're not doing
this
ortho.
orthodontic phase, is it through use Invisalign?
Yeah. This is Invisalign. And the cool thing with Invisalign is you don't have to wait, right? Like right when he's done doing his turning, he can start wearing retainers.
When do you start?
It's in the mail. It's gonna be like next week. I'm gonna start closing.
You're gonna start before me. I don't start until September. I slow down my turns a lot, and then I got a lot of. So I met a Brazilian orthodontist when I was in Amsterdam, Dr. George Faber, and he looked at me. He said, "Renata, you're turning too fast. In the next 5 years, there's some new research coming out," he said, "and people are going to start turning a lot slower." So he looked at me and said, "Try to do it once a week." So then I called my doctor and was like, "What do you think?" So he said, "Let's do it twice a week." So they met me in the middle. So twice a week now, but I only have 4 or 5 more turns and I'm done. I'm almost, the crossbite on the right side is almost done. It's getting there. But,
Looking good.
and then I'll start the Invisalign on top, but very good. I also can breathe better. I want to know, I know you guys have to go. I want to know a little bit more about the procedure itself. How do you get the maxilla to the suture to open in the middle? Because you're making one cut here, so I guess it's opening right in the front, right? Just like they do with the piezo. But then the other cuts are in the back?
Yeah, so you have to release the pterygoid maxillary junction.
Okay.
So I don't have a picture of it here, but basically the maxilla attaches to your skull base in the back.
Through here.
And if you don't free that up, you get almost zero posterior expansion. You're
Ooh,
going to
and
get like a purely anterior expansion because the maxilla is still fused to the skull in the back. So what we're doing is freeing the maxilla from the skull base, and then obviously doing a mid-palatal split that goes all the way back. But we're doing that without traumatizing the palatal mucosa.
And how do you do that?
So I also use a piezo. I also use chisels, and I go between the central incisors all the way back.
All the way back.
To the posterior nasal spine. Yeah.
Okay, that makes sense now. Wow, that is incredible.
That way you don't have a traumatic palate, right? Something that can happen is if you traumatize the palate and now you start expanding, you can develop more nasal fistulas, and it's also it's a lot more painful. The palate hurts, when you.
So it was never open in the palate then.
The palate's never touched. Yeah.
Okay. And then how painful was the procedure, Dr. Zaghi, and how was the recovery?
I was posting, I was up and out. I felt loose. I felt good. I think the biggest thing was like lip incompetence in this area. It was just really tight for maybe like a month out. And then I did like lip stretches and, like regained the good mobility. But that was the one challenging part. The other challenging part is the bands that are there. Really irritated my teeth. I have a lot of effractions and a lot of wear. And so the molar bands were irritating. He took them off a little bit early because I had the 6-screw Marpy. And so once the molar bands came off, it was a walk in the park. But I would say that those were the two biggest things that bothered me. I never had pain over here, like ever. He used, Marcaine. I was numb. Like I didn't have any pain per se.
Dr. Zaghi is being very modest.
Yeah.
He had the surgery on a Saturday, and he was seeing patients in clinic on Monday.
Of course.
That's Dr. Zaghi. That's amazing.
Yeah, I was back. Yeah.
And you have the 6 Tad Marpy. That's what you have right now.
Right? Yeah, I had a terrible gag reflex before. Like I couldn't even put that in my mouth without. They had to sedate me to even put it in my mouth.
Wow.
Yeah, and now I don't have a gag reflex. I can like brush all the way back. Like I'm like good. Like I couldn't clean it out at first. I was like gagging, but now, like I don't remember gagging. Like I don't like you can do a cleaning on me like no problem. Before I was always protecting my airway with the tongue thrust and the gag.
And what about the bruxism? Like, do you
it's better? Yeah, like way better.
Like your sleep is better.
I never had. Maybe I did a sleep study before and after. The sleep study is exactly the same. Like HI like 2.1 and like 1, and then the RDI of like 6 and 7. Like so, I never had any. I did a pre and post sleep study like a long time ago, and I tracked it out. No changes in my sleep study, but less nasal congestion, less clenching, grinding, less headaches, more symmetry, less neck and shoulder tension, lower back pain. And that's in combination with really dedicated body work and physical therapy and exercise regimen.
And how long does therapy stay in?
It's still in. I still have it.
For how long will that be in?
Honestly, I expect, to be honest with you, I expect some relapse as a result of the Invisalign. I anticipate that it's going to come down to like 40 millimeters. I'm guessing it's not supposed to, but I think it will. At which point I may consider some more skeletal expansion. My arch is still a little bit narrow because I had the prior dental alveolar expansion. My teeth were pulled out, so I'm almost cross-site right now. So the actual plan with Audrey Yoon, who's guiding it, is if I do anything more than this, I have trouble chewing. So we're going to bring the teeth in, hopefully push the teeth back into the bone, and then maybe expand a few more millimeters, and then close in for the finals. Because I still have tongue overflow. I still have a good amount of tongue overflow, but I can't expand more because my teeth were pushed out. Does that make sense? So I went from 34 to 37 teeth pushed out. And if I go more, then I can't chew. So I want the teeth to come in
To the bone.
while, while the palate's holding tight, and then to expand the palate further. I feel like that's what I want to do.
Yeah, like you have to upright the teeth in the bone before you do more
Right.
skeletal expansion. And that
Yeah.
happened for me on my left side. Something's wrong on my whole left side, but on the left side, my expansion might have been a lot more because I then had such a crossbody, couldn't chew on that side because my teeth didn't meet.
Mm.
So for a while, only chewed on the right side. So that changed some myofunctional.
That is like one of the biggest things, like biggest red flags of expansion is unilateral chewing, because things are moving and you're going for symmetry. So the unilateral chewing is something that everyone's got to be really aware of, whether
Yeah,
you want to use chewy tubes or do massage or not. Like the unilateral, it
Yeah.
pulls things really symmetrically.
Well, it's true because my teeth didn't meet on that side. So after, when I'm in the Invisalign now, so the teeth are being uprighted, and then my jaw gets so sore. I never had jaw soreness, but just like chewing a bagel or something, like it, or granola bars, it starts aching on that side because the muscles kind of atrophied probably. So it's definitely important to keep those muscles working correctly and bilateral muscle balance. Yeah, Renata, you're gonna say something?
I have a question because usually we are already, so I have not a bilateral, I only have a crossbite on one side, so I'm already asymmetrical. Obviously, when I am expand, I'm going to stay asymmetrical. But and I did do that, I chew more on one side now. So if you choose to chew more on one side, is that side going to expand more during the expansion or less?
It's the whole body is connected head to toe. So if you do have asymmetries, if you have like the shoulder impinge, for example, you twist your head to the side, or you have scoliosis or other things, then the asymmetry kind of holds you intact. If you try to make everything perfectly symmetric, it will cause more pain in other areas of the body. So symmetry itself is not necessarily the goal. The goal is like homeostasis, such that everything kind of works together. During my process, I had a perfect split, so everything is perfectly mobile. You didn't have surgically assist. You just had the mid-palatal split. You didn't have the pterygoid split, so you're not as mobile. But my maxilla is mobile. That means that when I chew sometimes, you could feel the maxilla popping up.
Ooh.
And when I felt the pressure here, I would stop. I would do craniosacral therapy. So I got like a book on it on how to do it yourself even, okay?
Of course it does.
Releasing and eliminating cranial strains, okay? Like there's like techniques that you can do to move the bones. People got to learn about craniosacral therapy. If you're doing expansion, you got to know what craniosacral therapy is. You got to know what myo is, okay? If you don't understand craniosacral therapy, you don't understand the bones in the face, okay? And if you don't understand myofunctional therapy, you don't understand what puts them there. So you got to get your tongue up. You got to get the chewing, all right? Because otherwise, you're going to be going off different ways. And if you have like cranial impingement, all right, well, then it's going to start to turn and twist in weird ways. And then maybe it looks okay here because you're forcing it, but then your shoulders are off, or your back is off, or your hips are off. So what I advocate for is I like the total split. So it's a neutral baseline. And then good exercise. I do swimming, I do yoga, Pilates, personal training. I do the body work.
Wow.
And I feel like that's helping my back become aligned, my shoulders, so that the homeostasis is as uncompensated as possible.
There you go.
Wow.
That's amazing.
Yeah.
That is a holistic man there.
Oh, it's gotta be. It's gotta be.
Yeah.
You guys want to see this book? Yeah. It's it teaches you like step by step how to do these. Like it's for dentists too. Like you can like learn. The guy gives courses.
That's awesome. I just took a photo. I'll share with you guys.
But craniosacral therapy, like the adjustments, you can learn to do it yourself once you see the bones. So like like just like move because it's mobile.
Yeah.
When you're fused, nothing works. But once it's free, the bones are moving and they adjust, and it's unbelievable. It's crazy.
You have to treat it right. Once it's all free, you're like a baby again, right? You've got to
like a baby, yeah. It's so amazing.
Oh my goodness.
That's why the mind procedure releases everything surgically so that you can have that potential. But if not, then you can still, bilateral chewing and things like that. Yeah.
Someone asked about the mandible. So you're just uprighting the teeth with Invisalign, right?
Yeah.
And in patients that don't have sufficient alveolar bone to upright the lower teeth to get the teeth to match, we're doing a lot of SFOT now, which is a procedure where you're doing corticotomies, adding bone, and that gives the orthodontist more real estate to upright those teeth, so you don't have to do mandibular distraction or anything like that.
Dr. Zaghi, we know that you have to go soon. I would love to ask Dr. Coppelson if you can stay a couple more minutes.
Sure,
If
yeah.
you're able to talk to us about the SFOT procedure. I know we have tons of questions about that. JJ just sent me a message.
Amazing. I'm going to say goodbye to everyone. Thank you guys so much for having me on. Thank you, Dr. Coppelson, for all your expertise and open-mindedness. And this was fun comparing our diastemas. You got
Look at this. Dr. JJ just sent me this photo. He's here. He's watching.
I love it. I sold out just with the mention. Amazing. Chromic, it's crazy, right? I'll say one thing. I'll say chromic suture, and then the demo companies will have no more chromic suture to get, okay? And then you mentioned like 𝐃𝐈𝐒𝐂𝐋𝐀, right? And then everyone's getting 𝐃𝐈𝐒𝐿. It's like no more 𝐃𝐈𝐒𝐿 in store. And then this book is going to go like out of stock. So you better get it.
You have influence. That is amazing. You have such influence.
That's amazing.
Wow.
Airway influencer.
Hey, when this goes out of stock, you let me know, right, Renata? Like it's like any day. Yeah.
Thank you, Dr. Zaghi.
All right,
we really
thanks for being here.
Thank you guys so much.
Thanks for all you do. Thank you so much. Dr. Coppelson, could you also explain the 𝐸𝐸𝑠 procedure and what that is?
Yeah, so the 𝐸𝐸𝑠 procedure stands for endoscopically assisted surgical expansion. It's a procedure that also provides three-dimensional expansion of the entire mid-face. It's done using a different type of expander than the one you guys had. So it's used as something called a TPS, which is a stock expander by KLS Martin. So it's not custom made. It sits on a shelf. You just fit it in anyone's palate. It goes just skeletal, so there's no dental component. It just screws into the palatal bone, and then you can activate it. The procedure is done through a combination of intraoral and intranasal cuts. So some of the cuts are done endoscopically through the nose, hence the name endoscopically assisted. And then a couple of the cuts are done in the mouth. That's 𝐸𝐸𝑠.
And is there like a lower success rate or anything with 𝐸𝐸𝑠?
No, I think it's very successful. It's a great procedure. It's just in my hands. I felt like I could do it a different way that would work better in my hands, so I kind of changed things up. That's all. There's nothing wrong with 𝐸𝐸𝑠 at all. I think it's a great procedure. Yeah.
And
I like using custom RPs because you get a lot of control, and where you place the screws, and
like crazy places.
There's so much art to like designing where the screws go, where the expansion screws go, the angle of like the vector in which you want to expand. Like there's so much I can do with custom RPs now that I'm like I'm always tinkering. Like the next one I'm tinkering, doing this, trying this. And I love that, right? So I think it's definitely the way to go. So
I was also recommended or as a consideration to do SFOT since I don't have a lot of bone on the bottom. So tell us a little bit about what is the procedure like in terms of pre-op, post-op, pain.
Again, it sounds crazy if I describe it to you. And it's really like not that bad of a recovery.
Okay.
I'm gonna sound like the biggest like surgery advocate that's ever lived. But I do take pride in like having surgeries, even my MMA surgeries where like the patients aren't wired shut and like they're like, this isn't as bad as I thought it was gonna be. So SFOT is a procedure where we do something called corticotomy. So we basically expose the alveolar bone. Okay, you can also do this on the maxilla, but I tend to do it more often on the mandible. You expose the alveolar bone, and then you do something called corticotomy. So you're going to cut the bone between the roots of all the teeth using a rotary burr, so not a piezo. You want it to be traumatic. The whole point of it is to induce like bone turnover and inflammation and stuff like that. So if you do it with a piezo, it actually doesn't work that well. So using a rotary, you're going to traumatize the bone between the roots of all the teeth, and then you're going to add bone graft on the outside, a specific type of bone graft, and then sometimes you'll even add soft tissue graft over the bone graft, and then close the gums over the top. And you do that for a couple of reasons. Number one, cutting all the bone causes that rapid bone turnover and inflammation, which speeds up the orthodontic process. So what might have taken 12, 13, 14 months of ortho is now 4 to 6 months of ortho.
Wow.
So ortho becomes like on steroids, which is great. And also because we're adding that bone, you have more real estate to upright and translate some of those teeth out into, to widen the alveolar ridge, widen the arch of teeth, so that when you skeletally widen the jaw up top, the teeth still fit and you don't have a weird Brody scissor bite thing going on.
Okay. And someone was asking about the FME. I think, is that the face genics maxillary expander?
Yeah.
Can you comment on that or explain what that is?
Yeah, so full disclosure, I'm an advisor to that company. So I'm excited about it. I haven't used it on a person yet, but I think it has a lot of potential. Yeah. So basically, the FME is an expander. It's a 6-tad expander with no tooth-bearing portion. So it'll just be like a thin piece of metal on the sitting on your palate with 6 screws, 3 on each side of the palate, and then you activate it. So it's very low profile. There's no dental components, so there's no tipping of teeth or anything like that, and it's very strong. I'm very excited about it. I just haven't been using it on people yet. I've been messing around with it on typodonts and stuff. And I do have, obviously I have some shares as an advisor. So,
and it's a newer
disclosure.
It's a newer developed type of expander, right?
Yeah, the benefits of it, right? It's going to be very strong. It's a very strong expander. The material they made it with. Having 6 tads is great, and then being very low profile is more comfortable in the mouth than some of the 3D printed ones, and then not having any component that touches the teeth, so you don't get dental tipping. So it has a lot of great components. I'm excited about its potential, and in the meantime, I'm having amazing success using custom marking. And I had amazing success with MSE. I mean, a lot of my cases I show off, like the guy Sam that Dr. Zaghi was showing off his cheekbones and his smile. He's just a regular MSE case, right? But always trying new things.
Yeah, Renata, did you feel like your cheekbones have changed?
A little bit. My cheekbones definitely have changed a little bit, not as much as I would like. What I like the most about it is that it feels like my maxilla has come forward a little bit. It could be just teeth tipping, but it doesn't look like my teeth have tipped that much. But my upper lip looks fuller, and I love it.
It's very common for the maxilla to come forward a little bit. So, millimeter.
We'll take what we can get.
Yeah, the
right? Yes.
The plates, it comes forward. I have patients say that all the time. I'm having a couple of patients right now experimenting with the reverse pull face mask. As part of the mind procedure is like, now that things are really loosened up with the mind procedure, let's slap a reverse pull face mask on there and try to get some anterior movement and growth.
That's amazing.
So I have my first 2 that are literally doing it right now, so I'm very excited to see how that goes. They're both very gung-ho compliant patients, so it'll be a really good test to see how they do. And
then we'll have you back to tell us about it.
Yeah, and the other stuff we're experimenting with now is no diastema expansion. So we have 3 or 4 of those going, and they're all going amazing. So that's going to be something we're going to publish on. So no diastema surgical expansion the whole time, controlling the diastema.
Really?
So we have a lot of cool stuff in the works right now.
So
I'm very excited about the future of maxillary expansion.
That is great. That is really interesting. No diastema expansion, because I think a lot of people avoid this procedure because they don't look like the photos we showed in the beginning. you know, I know people who are like, I know I need that procedure, but I'm not going to do that because I'm not going to have a year with that gap between my teeth. So
Exactly.
So there's a way now, and then we're gonna publish on it, you know,
Oh,
eventually.
very
So,
cool.
Amazing. Because
yeah,
my
always
biggest
keep learning, always
concern,
team.
the biggest concern is if you don't have that much bone over there, how stable are those two teeth, 8 and 9?
I mean, 3 for 3 so far. Obviously, it's very preliminary, but so far, I mean, you obviously need a surgeon that does things very well,
Uh-huh.
because if things aren't freed up the right way, it's not going to work. You're going to mess the patient up. You
Okay.
also need a very good orthodontist that also knows, and you work in conjunction. I mean, you can. It's not just like anybody can do it yet. Eventually, when you like publish a
Mhm.
protocol and the surgeon's good, and then obviously more and more people can do it. Right now, there's I'm only doing this with a couple orthodontists right now, and me. That obviously I do a lot of
Yes,
this type of surgery, so they've gone well 3 for 3 so far. But
that's
that's the
amazing.
future. That's going to be the future. Is going to be no diastema, um, surgical expansion cases.
Isn't that
So
be wonderful? Ah,
yeah.
Renata, you know how you said your upper lip? One of the things I noticed is I couldn't whistle, and I don't even know if I can anymore because I don't want to try because I feel like it's gonna push my like jaws back. But I could not round my lips to whistle with when I had the expansion. I still barely can, but I'm just not even gonna do
I
it.
know. I
Yeah,
can't whistle. I
it's
lost the
hard.
ability to whistle.
Yeah. I mean,
Um,
it's not like you're whistling all day or anything. It's not going to affect your life, but it is kind of a funny feeling to not be able to get your lips to make a whistle.
I don't feel like my posture has gotten much better. I really, really wanted that portion of the expansion. I mean, I'm still, a little bit too far back. Um, he did ask me to consider bimaxillary surgery to bring everything forward, but I'm not sure. I'm not sure. I'm not going to do it. I'm just going to do MRP, put everything back in place and call it a day. I think, I don't have sleep apnea. I don't have any issues at this point in regards. To me, it would be more aesthetics right now. When I get older, yes, I could still develop sleep apnea, but fingers crossed. I love the no diastema procedure. When I was talking to Dr. Faber, so I actually stopped turning just because I was going to go out of town for 2 weeks. It was my choice. I didn't tell my doctor. I just did it because it's me. I know, so bad. Um, but then when I heard that, Renata, it's the implants are in the bone, the TADs are in the bone. We're gonna start doing this, expansion in adults slower and slower. As long as they're in there, they're safe and there's no infection, nothing going on. There's no need for us to go so fast anymore. But of course, we all want things done fast. We don't want to sit with this thing in our mouth for a long, long time. It does change our speech. It is harder to swallow. But with all of this new research that you guys are doing and these new appliances and procedures, we're definitely in the last, 10 years even, we have come a long way.
Oh, insane. Like the way I do corrective jaw surgery is night and day from 5 years ago. The way I do
Right?
this surgery night and day. I mean, I feel like uh it's moving like at the speed of like tech, right? Like the surgery is moving as fast as the tech is changing, and
Wow.
the results are amazing. The type of expansion has changed, the results, the accuracy. Like, I mean, we're really living in a golden era of all this airway manipulation with the jaws and the teeth, and with ortho, like you have Invisalign now, right? They didn't have Invisalign 25 years ago, right? Everything's getting better and better and better, and it's a fun field to be in. It's very rewarding, right? Like Dr. Zaghi said, his gag reflex went away. I don't know if you had a unique something that happened, but all the time I have a patient tell me something different, right? Like there's the normal things like
Uh-huh.
breathe better through my nose, I sleep better at night, right? Those are like the common ones. But I had a patient say like I can smell better. Like I wasn't able to smell mustard for 25 years, and like I was with my wife and she got a hot dog and I was like, what the hell? Like, or the posture I hear all the time. And everyone gets something different. I'm off my anxiety meds, I'm off my ADD meds, I'm off my depression meds. Like, people's bodies decompensate in so many different ways when things aren't lined up perfectly, when things aren't functioning perfectly, and then hearing like the different like reactions to patients to have when you get them breathing better and sleeping better and feeling better, like it's pretty awesome.
Yeah,
So
you're affecting the whole system, the whole body. And what would be so amazing is if we can identify and treat these things in children at a young age, so we're not trying to unravel with surgery and cuts and all this to try to bring back to where we should have been, right? So it's all about early intervention, everybody. Right? I think we all want to get these kids taken care of.
yep, I had a patient come in today for a follow up with her little cute 1-year-old, and I was like, oh, I see a couple teeth there. I'm like, get him in to see Dr. Zaghi's wife
Next door.
now. So he's doing all the right things, so he doesn't need where you at, right? Like I did MMA on her, and she's like, great, she looks amazing. But I was like, you don't want him to have to do that, right? Like, get him started young. There's plenty
Yeah.
of work.
I've had so many patients where the parent has had MMA and they know to bring their child in because they don't want their child to have to go through what they had, not just surgically, but all the health ramifications that they had throughout their life, whether it's anxiety, depression, all those things that are potentially related to poor airway functioning and poor sleep. So they know, they're like, I don't want my child to go through this. Let's help them. So yeah, it's great. All the innovative things that you guys are doing.
We have
Thank
a
you.
question from Facebook. Can I ask you, Dr. Coppelson?
Yes.
First, Carrie said, really inspiring to hear the experience of you guys as professionals practicing what you preach. I'm on the fence right now, but seeing more and more of you guys do it is truly inspiring, and I believe it is to our clients as well. Chris is asking, or she said, thanks, Dr. C, for sharing your knowledge. And then she's asking, have you ever done any case where someone had osteoporosis?
Yes, I have. I believe one lady. Now, if someone has osteoporosis and they're taking medication to treat it, like a bisphosphonate or a RANKL inhibitor, like denosumab, then I would not do this procedure. You don't want to get hemorrhage. It's pretty nasty. If they do develop it, it's just not worth it, I think. That being said, if you just have osteoporosis and you haven't been on, bisphosphonates and RANKL inhibitors, then I don't think it's a contraindication to doing the procedure. Like, I would definitely have a talk with the patient. Like, you have a maybe slightly less chance of the bone filling in normally, and yada yada yada. Now, in terms of their ability to split, it's probably favorable, right? They have less bone density. So in terms of like getting them to split, it's probably a favorable thing to have some osteoporosis. The bigger issue is going to be like, how well is the bone going to fill in afterwards, right? So you're going to want to make sure you have their nutrition up to par, maybe, increase the calcium, the vitamin D, the K2, the protein, everything, make sure that they're optimized as much as you can.
Fantastic.
It's not a full contraindication unless they're on some of those medications that we talked about.
Okay. Nicole,
Yes.
you have anything else?
No, we covered so much. That was above and that was awesome. Such good information and such like new and innovative ideas and everything. So thank you so much for your time on a Friday. Appreciate it.
My pleasure. It's been really fun. You guys have the best podcast, super energetic. I'm starting out with the Guess the Gap. I mean, what a great way to get us started. I loved it. Thank
And
you
I
so
think
much.
you already have, I think, a lineup of people with the no diastema expansion. There's people commenting, I'll do it. So you're probably going to get a lot of people ready for that procedure when it comes out. Be ready.
Come on down.
All right. Well, thank you so much, Dr. Coppelson. We really appreciate you guys taking time out of your busy day to come talk to Airway Circle. Thank you, Nicole, for hosting the most amazing podcast. You guys have a wonderful night. Next week, we have somebody coming to talk to us about PRI. So Thursday night, 8 p.m. Make sure to join us. Thanks so much. Have a wonderful night. Mwah.
Happy weekend, everyone. Bye.